Welcome back, future doctors. Today, let's dive into a critical emergency, acute heart failure. In the United States alone, there are over 1 million hospitalizations for heart failure every year. Acute heart failure represents a sudden loss of cardiac function, which can result from ischemia, myocardial infarction, inflammation, trauma, or even toxic exposures like alcohol binge or drugs. Sometimes it's structural, such as papillary muscle rupture or a ventricular septal defect. The onset may be rapid, with a preceding viral illness, angina, or sudden dyspnea. Other times, patients have a gradual worsening of pre-existing chronic heart failure, with increasing weight, peripheral edema, and progressive shortness of breath. Clinical presentations include acute decompensated heart failure, hypertensive acute heart failure, pulmonary edema, cardiogenic shock, and rarely high-output failure. Now, the symptoms. Dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, cough, fatigue, and weakness are classic. Patients may also complain of confusion, insomnia, or abdominal discomfort. On examination, you'll often see tachycardia, hypotension, tachypnea, rales, jugular venous distension, hepatomegaly, ascites, and peripheral edema. For investigations, routine blood tests help exclude comorbidities, and BNP or NT-proBNP levels support the diagnosis. Chest X-ray shows cardiomegaly with pulmonary congestion. ECG may reveal ischemia, arrhythmias, or old infarcts. Echocardiography is the cornerstone. It assesses ventricular function, wall motion, and valvular pathology. Differentials include pneumonia, sepsis, bronchitis, asthma, and non-cardiogenic pulmonary edema like high-altitude, narcotic overdose, or transfusion reactions. Management begins with stabilizing the patient. Check vitals, monitor oxygenation, and get an ECG. Patients are often most comfortable sitting upright with legs dangling. Provide oxygen or non-invasive ventilation if needed. Reduce preload with diuretics and nitrates. Reduce afterload with vasodilators like nitroprusside, and improve contractility with inotropes like dobutamine or milrinone in select patients. Severe cases may require intra-aortic balloon pump or ultrafiltration. Remember, treat the underlying cause, whether it's ischemia, hypertension, or valvular pathology. Complications depend on the underlying disease, but prognosis is serious. In-hospital mortality is 3 to 5%, and 6-month mortality can reach up to 25%. So the key message is this: acute heart failure is a medical emergency. Recognize it early, stabilize the patient, and address the underlying cause to save lives. If you found it useful, don't forget to hit the like button, share it with your friends, and subscribe to the channel for more high-yield medical content. See you in the next video.